thank you very much for having invited me here to this meeting in Madrid to talk about hydration from the medical perspective. I'm a physician myself, and our perspective is a bit different from those that we see in research in demographic analysis, because we have in front of us usually a human being, single human being. It is not well at all. So we look at this from the hydration point of view. We look at this human being as a container of water with some solutes inside, and the solutes can be excreted removed from the body with the speed of 1200 milliosmoles per kilogram of urine. And the average man produces every day, average adult man produces every day, it would be nice to see, 1200 milliosmoles, more than average adult woman that produces something like 750, 800 milliosmoles per day. It means a man needs 1 liter of water to remove the osmoles that he produces, and it is much more than a woman needs, because she needs something like 700 milliosmoles, 700 milliliters of water to excrete all the waste she produces. And this perfect mechanism of controlling the volume of water outflow from the body and removal of the wastes can be nicely disturbed, but first of all, the living cells inside the body have their own mechanism of regulating volume. They keep volume very well, and they have the special mechanism of hyperosmotic regulatory volume increase and volume decrease. First mechanism that is switched on when the osmolality changes is either uptake or release of inorganic ions and water. If this is more prolonged, the cells produce organic ions which replace the inorganic ions inside the cells. They are less harmful, but they can be removed only with difficulty from inside the cell. Keeping the volume is very important because it translates in normal body into regulation of metabolism and gene expression. For example, dehydration of the cell starts apoptosis and inhibits proliferation. This intracellular osmolytes can be divided into two groups. One is the perturbing osmoles. They are electrolyte and urea. They are perturbant because even small changes in activity in their concentrations alter resting membrane potential, which transmits into transmembrane transport and enzyme activity. High concentrations or abrupt changes in concentration can trigger precipitation of proteins and damage the cells. And the so-called non-perturbing solutes, chaperone solutes, are organic osmolytes that are normally present in tens to hundreds millimoles per liter inside the cell, but and they do not any harm, but once they are very difficult to remove from the cell, which is really problematic when it comes to treating the patient chronically dehydrated. Especially this is true for the central nervous system. Because once you have the patient dehydrated and you start hydration, or the patient who is hyponatremic and you start replacing sodium, the regulatory mechanism switch on to prevent the changes of cell, and the cells keep swollen for several hours. So in chronic cases, you can be you have to be very delicate and very slow in regulating. This is not the case in acute settings. Also, when we try to treat the intracranial pressure. Usually you give hypertonic mannitol to take the water out of the cells. Unfortunately, the effect is not so ideal that it would be expected from the ideal osmotic behavior, and this can be restored only with giving furosemide or amiloride, just because the reactive replacing of volume is switched on. We know also that diabetes causes increased blood sugar. The blood sugar, also the intracellular sugar increases, which creates sorbitol synthesis, and the amount of sorbitol increases inside the cells, which replaces bioinositol in taurine inside the cells, which is very important, changes the behavior of the interior of the cell. And unfortunately, this also causes swelling of the cell. This is supposed to be the key mechanism for diabetic complications, diabetic neuropathy, retinopathy, but not diabetic nephropathy. Certain patients can be predisposed because it was proved that they have increased activity of the enzyme that creates this process, this sorbitol synthesis, and they are already inhibitors of this enzyme called aldose reductase are already in the market, but unfortunately they don't work very well. When we talk about water and osmolality, we mainly remember all the regulatory mechanism, but osmolality is not only water. Osmolality is also sodium. And the sodium is equally precisely regulated as the water is. The integration of this sodium and water metabolism takes place inside the hypothalamus. We as a physicians are much more interested in this integration of this water and sodium metabolism. Then this results normally in hyper and hyponatremia. Here you have the slide that shows that first of all, we regulate osmolality, but if the changes in blood volume are too big, the blood volume regulation prevails, and this is a classic SIADH syndrome, where the regulatory mechanism create euvolemia, hyponatremia, and salt wasting to control the blood volume in expense of osmolality. Because natremia is just the proportion between sodium and water. You can have hypovolemia and hypervolemia if the proportion of sodium to water is kept, you will have normonatremia. So we have to evaluate also not only the concentration, but also the volume of water. And this is not only important to have extracellular total body water, but also we have to see how much water is in extracellular volume, how much is intracellular volume, and how much is inside the arterial and venous parts of circulatory system, especially in the big arteries and in the left atrium, which are the so-called effective blood volume. So looking at the patient, we look at the total body water, hydration, to volemia, and especially the effective volemia. We look at the distribution of these fluids. We look at their osmolality and effective osmolality. It means tonicity. And all this creates something like 160 different clinical settings. Each of them can be acute, can be chronic, can be mild or moderate or severe. Fortunately, we don't have to remember all this. We like simple solutions, so we just try to understand what went wrong in this given situation, and usually it is not that complicated to discover. The acute states usually go to intensive care units, but the chronic dehydration that is so much seen in some populations mainly can result in disease diseases that are affecting urinary tract and the digestive tract and cardiovascular systems and so on. First of all, you've heard already probably that doctors advise the patient with urolithiasis to drink a lot of water. This is mainly based on the observation that if you are dehydrated, your probability of having kidney stones is much higher. But it is only one paper on a randomized study saying that really drinking more water releases and ameliorates the course of urolithiasis. The same holds true for recurrent urinary tract infection that is in even young girls related with decreased water consumption and less frequent voiding. Teaching young women drinking more and teaching them to void more frequently prevents recurrent urinary tract infection. So dehydration is bad, hydration is good. There are some conflicting informations about bladder cancer because urine is toxic and is hyperosmotic, brings injury to the system. So the bladder cancer is probably caused by this can be caused by this, but this situation. But unfortunately, we cannot see this very clearly from the inverse relationship between fluid consumed and bladder cancer frequency. But talking about coffee, this was nicely shown that only excessive amount of coffee, more than 5 cups a day, is carcinogenic. The urinary bladder cancer increases with age, which means the most probably the repeated injury to the urinary bladder increases the really probability of developing cancer. So it is good to flush the urinary tract with a large amount of water. But it is also important for the kidneys. In this study made in Australia in 3 heat waves in short period of time, the frequency of hospitalizations in hot days was higher as compared to days with normal temperature, but only in women, regardless of age. The main reason was acute renal failure and other renal diseases. And as you can see, it is true. Dehydration is responsible for every 3rd patient admitted to the hospital for medical reasons, and this affects mainly elderly, but this I think Professor Ritz will talk later. Also in the big study of 30,000 patients admitted to the intensive care units, 25% of them were admitted for dehydration. This is really bad story. This is even more in adults, in elderly, because this is the dehydration is responsible for 30% of admittances to these very expensive units, and in children, up to the 30% cases of intensive care hospitalizations is also admitted in developing countries due to acute renal failure. The epidemics of renal failure is in front of us. Why? In last couple of years, the incidence in all age groups in the United States increased 3-4 folds. As you can see. So yes, more and more, and majority of them is dehydration. Acute renal failure is not benign disease. It aggravates the course of renal failure. It increases the mortality. It increases the probability of getting dialysis, which is extremely costly, and it increases the probability of getting hospitalized within the coming year. So it's very bad, and the Americans decided to put this condition into their Healthy People 2020 strategy. And to prevent the damage to the kidneys is very easy. Normally, it takes hydration. So dehydration is bad, hydration is good. We also know, everybody knows this, that ADH activates V2 receptors in kidney, which activates aquaporins, activates urea transporters, but we tend to forget that ADH also causes sodium retention, which is especially dangerous in people with polycystic kidney disease. The cysts inside the kidney originate from the distal part of the nephron, which is susceptible to ADH, and it takes the cysts take water and sodium, which destroys the kidney. The cysts grow. This can be prevented by antagonists of ADH receptor, but it can be also really nicely stopped by increasing pure water consumption, because then you don't have ADH and the cysts don't grow. The ADH is nasty, really, because it also activates V1A receptor, which contracts the arteries, and it stimulates V1B receptor, which secretes ACTH, and all this means AVP is really adds up to the pathophysiology of hypertension, which is now a very interesting field of studies. But you have to be ready with hydration. It is shown very nicely in studies that if you are well hydrated, your chances of surviving fatal cardiac heart disease are higher. Your chances of surviving stroke are higher, and if you are properly hydrated, not dehydrated or overhydrated, then your chances of getting out of the hospital home are even higher. So, as you can see, that hydrating is important, and you should keep yourself well hydrated, otherwise you decrease your chances of survival. Skin is to protect our interior water of evaporating. So the mechanism taking water to the surface of the skin in dry surrounding is not enough and not efficient enough, and you need to put some emollients on the skin to prevent it from drying. Unfortunately, the bad message is it does not prevent from wrinkle formation and from skin aging. Bronchi are the other surface exposed to the external ambient, and you can see drying the bronchi can result in asthma attack. This is so important to keep yourself hydrated because dehydration also affects tissues that hard as teeth. Number of conditions that make hypofunction of salivary glands or decrease the salivary production can increase the tooth wear, and the Australians even invented a national strategy called WATCH to increase water and calcium consumption in the population. Finally, gastrointestinal tract. There's a very conflicting results because it is well known that decreasing water consumption is associated with constipation, and constipation can create colon cancer. Unfortunately, I don't know any reliable study that could show that increasing water consumption decreases the colon cancer. Maybe the gallstones can be prevented with increased water intake, but it's only one paper in Chinese, and I couldn't really read it well. Number of diseases are associated with hypohydration. It's cystic fibrosis, it's diarrhea, and hemolytic uremic syndrome in children. Even weaning food and formula food really can dehydrate children. Even our medical treatment with drugs and giving contrast media to what is more and more frequent really is deleterious to the health. So water consumption is probably very good for your health, but is it safe to drink a lot of water? And we know, yes, it is safe. Because central diabetes insipidus, renal diabetes insipidus, psychogenic severe polyuria normally doesn't give any negative effects. Also increasing the fluid intake in men with some symptoms from the lower urinary tract does not result in any negative symptoms. So it looks like it is safe to drink. And the situation in which drinking a lot of fluids are dangerous to healthy people are very easy to prevent because it happens only in long-distance runners or working or exercising in a hot environment. Unfortunately, forced drinking of children also can do this. We doctors also can add up to this danger because we give sometimes gastric lavage, especially in children. Sometimes the urologist flush the post-surgical bed with water, and this can be really not nice for patients. So it is safe to drink a lot of water. And in patients on dialysis without kidney, it is slight overhydration is even beneficial for their survival. Severe overhydration is very bad, increases mortality. So the problem is that you have to keep hydrating yourself permanently because all the efforts to keep the water inside the body is really difficult, and the excess of water is rapidly removed, something like 70% every 2 hours of excess water. So this brings me to the point that do we have any recommendations, medical recommendations, how much water is enough? And from what I said, probably the most important is to keep the urine hypoosmotic to the plasma, so you don't stimulate vasopressin release. This would need 4 liters of urine a day for a man, and 3 liters, 2.5, 3 liters of urine for a woman. So maybe it's not about drinking, but about voiding. This obviously cannot be advised to people with renal failure, with severe protein sodium restriction, with heart failure, renal failure, edema, on diuretics, and abnormal voiding mechanisms. So this, I would like to conclude that water intake is known to have positive effects. This is proved. Few negative effects, or dehydration is really bad for your health and aggravates and changes the course of many diseases. Hyperhydration is seldom of any danger to healthy people, and frequent voiding seems to prevent the urinary bladder cancer. So the message to the home is void a lot, drink a lot, and feel healthy. Thank you.